All right, good afternoon, everybody. Why don't we go ahead and get started? It's just a minute after the hour. Let me first start by welcoming all of you again to our monthly public health webinar. Today's topic, as you can see on the screen, is going to cover gonorrhea, chlamydia, and doxycycline post-exposure prophylaxis. I am recording this webinar, and it will be posted online afterwards, similar to the syphilis webinar that we conducted a few months ago. And we're going to start off here with Dr. Altamare from Dartmouth-Hitchcock Medical Center presenting on the national epidemiology of gonorrhea and chlamydia, and then talking and giving a brief clinical didactic on testing and treatment recommendations for chlamydia and gonorrhea. And then I will take over and talk about New Hampshire-specific epidemiology very briefly, and then talk about doxycycline post-exposure prophylaxis. Just as a reminder, the chat function is reserved for us posting links and information to all of you. If you have a question, please use the Q&A box. We will not be taking hand raises or verbal questions, so if you have a question or comment, please use the Q&A box, which can be found in the Zoom toolbar. Also, as a reminder, these slides will be posted online on our healthcare provider website, which hopefully all of you are familiar with. Would also encourage you all to go back and watch the earlier companion webinar to this one that was recorded and posted online about syphilis and congenital syphilis. That is also on this website. So with that, why don't I hand things over to Dr. Altamare, and she will get us started here by talking about the national epidemiology of gonorrhea and chlamydia, and then briefly talk about testing and treatment recommendations before I take back over midway through. So Antonia, go ahead.
Thank you, Dr. Chan, and thank you all for signing on. Another one of my favorite topics, gonorrhea and chlamydia. So this kind of first intro slide kind of gives you high-level statistics of how many people in the US have an STI. And so as of 2018, this data was 1 in 5, and of most significance is about almost half of the new STIs were among youth aged 15 to 24. Next slide, please. So just to set the stage, the newest data we have is actually from the year 2022. And as you can see, there were 1.6 million cases of chlamydia and around 600,000 cases of gonorrhea. These are newly diagnosed cases. And so for chlamydia, it seemed like it was a slight decrease compared to 2018 data, but gonorrhea has been on the rise. And we've touched on in prior lectures syphilis, so I'm going to skip over that statistic today. Next slide. As you know, if left untreated, STIs can cause an increased risk of giving or getting HIV. There are also long-term pelvic or abdominal consequences, such as pain and infertility. So the real key is to talk about it, test for it, and treat it. Next slide. So just to give you kind of a landscape of what STIs are most prevalent and where new infections are happening, and a reminder that prevalence is the estimated number of infections that people are living with at any given time, and incidence is really the estimate of new infections diagnosed or undiagnosed. And you can see here, far above many others, HPV remains the most common sexually transmitted infection, followed by herpes, HSV2, and Trichomonas chlamydia make up kind of the top 4. In fact, all of these make up around 98% of all prevalent STIs and 93% of all incident STIs. So although we talk a lot about syphilis and gonorrhea, they are overall less numerous than chlamydia and some of the other infections. Next slide. So just wanted to kind of give you what these infections have been looking like over time. So we're going back really far in some of these graphs. For chlamydia, the upper left, you can see this graphic is from the year 1984 until around 2020. And the overall general trajectory looks a little bit like the stock market. So overall has been going up. Where the arrow is, that's where the US CDC had decided to make this a national identifiable condition. So you can see that it was plateauing a little bit before then, but once reporting had kicked up, you can see that it's been nothing but up. Of note, there's a few hiccups or bends in a lot of slides between the years, 2020 and 2022. And that actually has to do all with the COVID pandemic, where testing had actually dropped off. And so we saw less cases, but that doesn't mean there were less cases. It was more of a testing void. So if you look over at the top right, gonorrhea, that graphic definitely looks different. And the year span is really 1941, so 40 years prior to where the chlamydia slide starts. And you can see that there was a nice dip in and around the 60s, which actually we could probably attribute to penicillin back in the day. That's no longer the recommended treatment for gonorrhea, but its cousin is. And then you can see how there was a spike in the 80s, came back down in the early 2000s, and now we're on our way back up. Just looking at some of the more specific demographics when it comes to age and gender, they are different between chlamydia and gonorrhea. You can see for chlamydia, the bottom left box, that there are more females infected with chlamydia. And if looking at gonorrhea, there are more males, but the age distribution is very similar and tends to affect, again, that youth-aged population. Next slide. The other thing to point out is for both chlamydia and gonorrhea, this graphic looks exactly the same. And that is the fact that ethnic minorities are disproportionately affected by these infections. So you can see on the left, white and purple, that's the percent of the population that white people make up and what percentage of infections are made up of white people. And similarly for Black being the most starking kind of color, that goes pretty much from pretty low down on this graphic at 12% of the population. However, Black African American make up about 28% of all infections. Next slide. So the disparities. So as previously stated, 50% of reported cases of STIs were among adolescents and young adults, age 15 to 24 in 2022. And 31% of all cases of chlamydia, gonorrhea, and syphilis combined were among non-Hispanic, Black, or African American persons, although, like just stated, they make up the minority of the US population. And men who have sex with men are disproportionately impacted by STDs, including gonorrhea and syphilis. In fact, 36% of men who have sex with men who were diagnosed with syphilis also had concurrent HIV. And so the quote from the CDC is that these disparities are unlikely explained by differences in sexual behavior and rather reflect differential access to quality sexual health care, as well as differences in sexual network characteristics. Next slide. I also wanted to note that not only are the absolute numbers of infections going up, but we're having an increasing problem with antibiotic resistance. So this graphic just shows different types of antibiotics specifically used for Neisseria gonorrhea and the percent that have increasing MICs, or that minimum inhibitory concentrations, which essentially makes them less effective against the bug. So half of all infections in 2022 were estimated to be resistant or have some elevated level of minimum inhibitory concentrations to at least one antibiotic, but almost all the circulating strains in the US remain susceptible to ceftriaxone, which is the primary recommended treatment for uncomplicated gonorrhea. Next slide. In fact, some of you may have seen this HON that came out now a little over a year ago, January 2023, where there have absolutely been reported cases of resistance or reducedly susceptible gonorrhea in Massachusetts. And so the HON really reiterated the importance of screening, treating, and if suspected treatment failure, to really obtain a culture, which we'll talk about when we talk about diagnostics. Next slide. So we can't really talk about STIs without talking about sex. And I may have mentioned this before, but a sexual history taking should be taken as part of routine healthcare. And I know when I was in med school and in training, this was not a huge part of my training. Talking about sex is uncomfortable for a lot of reasons. But it allows you to really provide high quality patient care by appropriately assessing and screening individuals for a broad range of sexual health concerns and an opportunity to educate patients, normalize those behaviors, and discuss harm reduction. Next slide. So the CDC puts out this wonderful booklet. It's the size of a pocket, so it can easily fit in your pocket. And it follows the 5 Ps of sexual history taking. So these are kind of the 5 categories you should be addressing when speaking to patients. Who are your partners? What do you do with them? Do you use any protection from STIs? What are your past history of STIs? And what are your pregnancy intentions? They actually have wonderful quotes in the booklet on how to actually frame the question and be able to risk assess that patient. This is important because when it comes to screening, it's really important to screen all sites of exposure, and that might not just be a urine specimen. Next slide. So what are the recommendations? So these are the latest USPSTF screening recommendations for gonorrhea and chlamydia. For all sexually active women, 24 years or younger, or 25 years and older with increased risk, which you'll see below, it's recommended that they be screened for gonorrhea and chlamydia. So what does it mean to have increased risk? It means a previous or coexisting STI, a new or more than one sex partner, a sex partner having sex with other partners at the same time, a sex partner with an STI, inconsistent condom use when not in a mutually monogamous relationship, a history of exchanging sex for money or drugs, or a history of incarceration. On the other hand, the recommendation for men is that the current evidence is insufficient to assess the balance of benefits and harms of screening routinely for chlamydia or gonorrhea in men. I do want to point out on the next slide, please, that the CDC, as of 2021, had updated their screening guidelines. And not only do they list it by disease, but you can list it by population. So I wanted to bring your attention to the category of men, in particular, men who have sex with men. Next slide. There actually are very specific recommendations for screening men who have sex with men. And it's recommended that this be done for both chlamydia and gonorrhea at least annually for any sexually active men who have sex with men at sites of contact. So that would mean urethra, rectum, and in the case of gonorrhea, the pharynx. And if they remain at increased risk, it's recommended to do it more frequently, perhaps as frequent as every 3 to 6 months. So you can see how this differs slightly from the blanket statement from the USPSTF, where they, it's a grade I recommendation because there's not particularly strong evidence to screen all men. But if you get down to kind of risk categories, you can see that there may be indication to screen certain men. Next slide. So how do we screen? The gold standard for chlamydia and gonorrhea is a nucleic amplification test. This can be done on various specimen types. Vaginal or cervical swabs are sufficient for anyone with a vagina, or a first void urine, which tends to be a little more difficult because by the time you're seeing a patient in your schedule at 2 o'clock in the afternoon, they've certainly already voided. Patients can collect their own specimens, and a vaginal swab collection is equivalent in sensitivity and specificity to those collected by a clinician. The same goes for urine samples, being comparable to a cervical or urethral swab, as long as it's a first day collect. You can also use these swabs for the oropharynx, the rectum, and in babies, we often use it for the conjunctiva. The key here, however, is to test all sites of exposure. Next slide. The reason being, there's now 2 well-documented studies looking at positivity rates and incidence of STIs in various populations. And in this first one, you can see that extragenital gonorrhea and chlamydia were common among MSM, men who have sex with men, attending this particular STI clinic, and more than 70% of extragenital gonorrhea infections and 85% of extragenital chlamydia infections were associated with negative urethral tests at the same visit, and hence would not have detected up to, in this case, 85% of infections if only the urine or the urethra was screened. This same thing has now been proven and seen in a separate study done in a cohort of patients infected with HIV at a HIV clinic who had multiple site testing. And in this cohort found that 96% were positive only at an extragenital site. We have pretty much the same experience within our HIV population and in our clinics, whereas if we do multi-site testing, almost always the positive tests are coming from anywhere other than the urine or urethra. So if you can't remember the words, remember this image, and I apologize if I've ruined ice cream sundaes for the rest of your life, but remember the triple dip. You're going to test for rectal, urine, and pharyngeal, gonorrhea, and chlamydia, with the caveat that there's actually not enough evidence to screen for chlamydia in the pharynx because the clinical significance is not well known. So it's not actually a routine recommendation to screen. However, if it's found because you're using the same swab and both tests are run on the same swab, then you should treat because you certainly can transmit if there's chlamydia in the pharynx. And then the chocolate sauce and cherry are the HIV, syphilis, and in the case of rectal receptive sex, hepatitis C serology. So all of these are potential infections that can be acquired through sexual contact. The top HIV, syphilis, and hep C are blood tests, and all the others have to be done through either swabbing or urine collection using very specific swabs. So the next slide will show you exactly what that means. So the swab that you should have on hand is, and this is just one manufacturer, it's a collection swab for endocervical, and it's labeled in male urethral specimens. But again, it can be used and is FDA approved for use at other sites. How do you do it is the most common question I get. And it is quite simple. If you've ever done strep tests, swabbing the oropharynx is very similar. You want to swab both tonsils, pillars, the back of the oropharynx, and all the way around. So you can make one big sweep, like in an upside down U fashion, and you've got your specimen. You put that right into the tube and you label that with obviously a patient label, but label it throat because you're going to be sending down several specimens, and you do need to know which specimen is positive if there is one, because treatment guidelines may differ. For rectal swabbing, just as easy. You take out that blue swab and you stick it about an inch into the rectum and twirl it around for about 10 seconds. Both of these swabs can be done by the patient. In fact, most patients opt to do the rectal swab themselves. Most have a little more difficulty self-collecting the oropharyngeal swab. And finally, the last picture is a picture of a vaginal swab, which again, most patients opt to self-collect. Same maneuver, about an inch or two into the vagina, spin it around for about 10 seconds, put it into a separate vial. So it should be separate swabs, separate vials for all specimen site collections. Next slide. So what are the treatments? So you do all this swabbing and you get test results back. 2021 guidelines have changed quite significantly from the prior iteration for STI treatment. And probably the biggest change was in the treatment of chlamydia, which azithromycin used to be the mainstay of treatment, has now been moved to the alternative because doxycycline has proven to be much more effective, especially when treating rectal mucosa for chlamydia. So the newest guideline and recommendation for treatment of chlamydia is doxycycline 100 milligrams orally twice a day for 7 days. So you might ask, gosh, the adherence to this is going to be a lot less than the azithro 1 gram, which used to be a single dose. We haven't found that to be the case. Most people do just fine taking it, but know that if you worry about adherence, you can use the azithromycin. They're just maybe lesser efficacy, particularly if you're trying to treat rectal mucosa. Advice to the patient should be that they should abstain from sexual intercourse for the first 7 days of treatment, because that's about how long it takes to be effective. Otherwise, they could potentially still be at risk of transmitting infection. And partners have to be notified, and we often leave this up to the patient. And partners means anyone that they've had contact with in the last 60 days of diagnosis should be tested and treated. And anyone who receives a diagnosis of chlamydia should certainly be tested for HIV, gonorrhea, and syphilis, which you're doing probably chlamydia and gonorrhea at the same time. But don't forget, up front, if you're testing for STIs, it means you should be testing for all of them. Great. So a word of caution on a particular strain of chlamydia, which we've definitely seen clinically here, and that is a syndrome known as lymphogranuloma venereum, which is caused by a very specific serovar of chlamydia trachomatis. It's L1 through 3. And it causes a very different syndrome. So what I haven't mentioned so far is that most cases of chlamydia and even gonorrhea are asymptomatic. So the intent of screening is to pick up on asymptomatic infection and screen it. Certainly, if someone comes in with symptoms, you absolutely should be testing for and treating any positive test that comes back. But in the case of this particular bug and syndrome, this is very symptomatic and severely symptomatic. It often causes tender unilateral inguinal lymphadenopathy. It could cause genital ulcers, but the syndrome we see most is that of proctocolitis, which for all intents and purposes mimics and looks exactly like IBD. It has significant colonic inflammation, diarrhea, maybe constipation, blood, mucus, colonic fistulas and strictures that could develop. And this isn't over a prolonged period of time. This inflammation happens very quickly, but will persist without treatment. And in fact, I've had patients who've been seen by various GI colorectal surgeons, and they, just assumed it was all new diagnosis of IBD. But the diagnosis is getting a rectal swab for GC chlamydia, or in this case, very specifically chlamydia, the same chlamydia you're testing for in the other slides that I mentioned. So a simple swab of the rectum will give you the answer. If it comes back for chlamydia trachomatis and they have this syndrome, then essentially you can say they have lymphogranuloma venereum and need treatment for that, which is, as you can see, different than the 7-day course you would give for asymptomatic rectal chlamydia. So this is a 21-day course of doxycycline, and symptoms should completely resolve. There is no commercially available test to actually tell you the serovar of the chlamydia. So this diagnosis and treatment is really based on a combination of the clinical syndrome and a positive rectal swab. Next slide. Great. So moving quickly on to gonorrhea. There were also some updates to the treatment of gonorrhea, and that mainly had to do with the dose of ceftriaxone. So ceftriaxone has been the mainstay of treatment for quite some time now, because as you remember, ciprofloxacin, azithro, other antibiotics that used to be used are now quite resistant. The change here to overcome some of the rising MICs is a higher dose, and to note that it's a 1 gram dose for anyone who's over 150 kilos. So really pay attention to the weight of the person and the dose needed to treat gonorrhea. The treatment is the same regardless of the site of infection. However, there's one difference, and that is if you're treating oropharyngeal gonorrhea, a test of cure is recommended at 7 to 14 days, because the ceftriaxone tends to be a little less effective in penetrating the oropharyngeal tissue than it is the other sites. So we are on the side of retesting around 14 days, because you are testing again with a nucleic amplification test. And if you test much earlier, you may pick up on non-viable organism, and it could be a false positive. What you're really looking for is failure of treatment in this case. And if the person's actually symptomatic in any of these sites and you're treating for gonorrhea and symptoms persist despite treatment, then you really need to repeat not only a nucleic amplification, but send a specimen for culture, because this will be the only way to get antimicrobial susceptibility testing. And with the rise in the number of resistant isolates, this now should be the new norm if you have persistent symptoms in the setting of symptomatic infection. So there are alternative regimens, but they're not great. So you can see here, if someone has a true cephalosporin allergy, then you're looking at gentamicin and azithromycin. So it's not easy, and I would make sure for all those I'm putting air quotes around this word, penicillin allergic patients truly have allergies, and try to flesh that out before deciding that you're not going to give them first line therapy. Next slide. Great. So follow up. Test of cure is pretty much not advised for non-pregnant persons, but what is recommended is repeat testing for anyone who's had a positive test at 3 months after treatment. And the reason there is not because we're looking for failure of treatment, but you're actually looking for reinfection, because the reinfection rate is really high, especially if partners don't get treatment at the same time. The only caveat to that are pregnant women. They always fall in a category of themselves given the risk to baby. And so in particular, when it comes to chlamydial infections, it is recommended that they actually have a test of cure at 3 to 4 weeks after treatment. Next slide. Great. So here we are at the end. If you take away nothing else, STIs are on the rise. A detailed sexual history is really important. Testing all sites of exposure are the most important. Remember your triple dip and the swab you need to use, and treat per the updated CDC guidelines. The link to the guidelines are on this slide and were referenced in the previous slides, and you can go to the next slide. The other, kind of like little logo or slogan to remember that HRSA is actually pushing out is this ask, test, treat, repeat. It's as simple as that. We need to ask, test, treat, and repeat. And there's a little YouTube video there that you can watch too. Here are the references, and know that the STI guidelines are available through an app, super easy on your phone. When you click into it, you can click on the disease entity. It gives you all the treatment recommendations right there. So if you don't happen to be, someplace where you're on a computer, or they also have wall graphics, pocket cards, things like that. Super important information to keep handy. And that's it. Thank you.
Great. Thanks so much, Dr. Altamari, for that excellent review. I am going to take just about 5 seconds here to switch slides. We weren't able to combine them into one single deck. My apologies for that. And then I will pick up and take over here. And Antonia, can you just confirm that you can see my slides now?
Yep, in the correct presentation mode.
Perfect. All right. So thank you again, Dr. Altamari, for that excellent clinical review. I'm going to talk very briefly about the epidemiology of chlamydia and gonorrhea in New Hampshire, although I'm going to move fairly quickly through these slides because the patterns and the trends are very similar to what Dr. Altamari showed with the national epi. So this is a graph of the total number of chlamydia infections diagnosed each year in New Hampshire, going back to about 23 years to the year 2000. So not quite as far back as some of the national graphs that Dr. Altamari showed, but you can see that the trend here is very similar, where for a good decade plus, we saw gradual and continual increase in the number of chlamydial infections each year. That peaked at just over 4,000 infections before it has slowly downtrended, when last year in 2023, we were almost at 2,800 chlamydia infections. But the trend here is very similar to the national picture. And if we stay on chlamydial infections, this is a graph looking at the total number of infections in New Hampshire by age. And this is actually looking at the last 3 years of data combined. So 2021 through 23 data is combined here. And again, you can see that the majority of chlamydia infections are occurring in older adolescents and people in their 20s and 30s, which is consistent also with the national picture, and is not surprising given that this is partly where the screening recommendations focus. And this contrasts with what I'll show you in a few slides around gonorrhea, where there is a higher number of infections in older age groups. This is looking at the number of infections in New Hampshire by county. Again, the 2021 to 23 data is combined here. And you can see that the burden of infection really is focused around the southern and central parts of the states, with Hillsborough County having the highest number of chlamydia infections, followed by Rockingham, and then Stratford and Merrimack counties. When we look at risk factors or reported sexual risk factors, you can see that the vast majority we don't have information on. So more than 2/3 of people diagnosed with chlamydia, we don't know what their sexual risk factor is. And then another quarter plus report heterosexual contact. One of the main reasons for the large unknown category is simply the fact that we have so many chlamydial infections that many, if not most of them, don't get the full public health investigation to determine risk factors and sexual partners. It has just become a burden that is unable to be sustained when doing public health contact tracing. Hence, we don't have a lot of information on the people who are diagnosed with chlamydia. When we look at gonorrhea trends, this is a graph looking at the total number of gonorrhea infections in New Hampshire each year, going back to 2000, the year 2000. You can see that this is very similar to the national trend. For a good decade plus, we had a relatively stable level of gonorrhea infections at about 130 or so per year, and then began to see a dramatic increase around 2015, 2016, where we actually did healthcare provider messaging at that time. So some of you on this webinar may remember that messaging back then about the dramatic increase in gonorrhea. That had continued to go up and has not come down. 2022 saw the most number of gonorrhea infections at just over 670. Last year, about 591 gonorrhea infections were diagnosed in New Hampshire. So we saw that dramatic increase back in 2015, 2016, and the numbers have remained high since then. In terms of age groups, you can see that still people in their late teens, 20s, and 30s are largely impacted, but we do see a shift to older age groups, which is also consistent with national gonorrhea trends that Dr. Altamare showed earlier. In terms of the geographic area impacted in New Hampshire, this is similar to the prior graph I showed for chlamydia, looking at the total number of gonorrhea infections now in New Hampshire by county. And you can see similarly that Hillsborough County has had the most number of infections diagnosed, followed by Rockingham and then Stratford and Merrimack counties. And then similarly with reported sexual risk factors, there's about half of people diagnosed that we don't have or don't know the sexual risk about or on. A little over a quarter report heterosexual sexual contact, almost a quarter report men who have sex with men. And so this is also not a surprising trend here. So what are the strategies that we have to prevent the spread specifically of chlamydia and gonorrhea? And I'm specifically calling out chlamydia and gonorrhea because with some other sexually transmitted infections, for example, HPV, we have a vaccine. Hepatitis B virus, we have a vaccine. HIV, there are strategies like HIV pre-exposure prophylaxis or PrEP that is utilized. But with chlamydia and gonorrhea, there is no vaccine. And so a lot of our control methods focus first on behavior modification and risk reduction strategies. So, asking patients or recommending patients reduce the number of sex partners, have, lower risk sexual encounters, wear condoms, et cetera. And that frequently is not a successful or long-term successful strategy. And so then we look to healthcare providers and the healthcare system for secondary prevention, right? Early detection of infection through screening and testing, as highlighted by Dr. Altamare, appropriate treatment, retesting if appropriate. As I alluded to, contact tracing to identify exposed and susceptible persons oftentimes is not successful, either due to the burden of infections and reports coming in, or the simple fact that many people do not want to or are unwilling to share very personal information about their sexual contacts. And then there are strategies that have been talked about previously around expedited partner therapy. That's where providers treat partners without necessarily having a clinic visit to assess them, But that is also difficult to implement from a clinical perspective. So there are a number of different strategies that are used to prevent the spread of chlamydia and gonorrhea. And yet over the years, we have continued to see rates of these infections overall continue to rise. And so new strategies need to be employed and investigated. And that's where transitioning now to doxycycline post-exposure prophylaxis comes in as a potentially important tool for controlling the spread of specifically bacterial STIs. This is a table from some draft guidelines that CDC put out a number of months ago. This is coming, but this is not yet formally released by the CDC. And so you may have heard about this in the media, or you may have seen stories about this. You may have even seen the draft guidelines themselves when they were released a few months ago. And you can still find them online. But here is a high-level summary of what we expect is likely coming from the CDC in their doxycycline post-exposure prophylaxis, or PEP guidelines, where there's a recommendation based on a high quality evidence that doxycycline 200 milligrams taken once orally within 72 hours of sex can be considered for gay, bisexual, and other men who have sex with men, including transgender women who are at higher risk for STIs, or, as defined by having a history of at least one bacterial STI in the prior 12 months. So a lot of information there, but that is the population that CDC is looking at recommending doxycycline PEP for, based on studies that I will be showing you here in the subsequent slides. There is no recommendation. They have the second row here. We expect that they will release guidance that there is no recommendation given at this time for the use of doxycycline PEP in cisgender women, cisgender heterosexual men, transgender men, other queer and non-binary individuals. If this intervention is offered, it should be implemented with considerations for ancillary services as detailed below in their guidance. So this is not a recommendation against using doxycycline PEP for these other groups, just acknowledging that there is insufficient evidence for a strong recommendation for doxycycline PEP in these groups. So this is, again, draft doxycycline PEP guidance, which we expect is coming from CDC very soon, in the next month or 2 months or 3 months, hopefully. And what I wanted to do was just take a little bit of time and walk through 3 studies, published studies, which this guidance is largely, I think, being based off of. And so first, let me apologize that the next few slides are going to be a little bit text heavy and data heavy, but I think it's important information. So the first study to really look at this and be published was a randomized study published back in, I think it was 2017, 2018 in the Lancet, where they did a subgroup study. So it was an amended study of high-risk men who have sex with men that were originally studied to conduct, that was originally conducted to study the efficacy of HIV PrEP. That's, prevention of HIV with the use of tenofovir and emtricitabine, which many people know as under the brand name Truvada. But they took a subgroup of this larger study and looked at the efficacy of doxycycline PEP in France at preventing bacterial STIs. So this was a study conducted in France. It was an open label study, meaning participants knew if they received doxycycline or not. And participants had to be adults, either men who have sex with men or transgender women having sex with men. They were HIV negative, right? Because they were all initially being studied for HIV PrEP. And they had to be at high risk for HIV acquisition. And so they were randomized to doxycycline versus a standard of care. And with the doxycycline PEP group, that group was instructed to take 200 milligrams of doxycycline once within 24 hours, but no later than 72 hours after each high-risk sexual event. And they instructed participants to take no more than 3 doses per week. They studied the occurrence of a first bacterial STI, and they combined chlamydia, gonorrhea, or syphilis into one primary outcome measure. They followed up these patients every 2 months with testing for chlamydia, gonorrhea, and syphilis. Testing for chlamydia and gonorrhea was conducted through throat and rectal swabs and urine. And they also assessed doxycycline adherence. And in the table at the bottom, you can see the follow-up that they had, the numbers of people, and the proportion that followed up every couple of months for the different groups. And you can see that follow-up was pretty high across the study. And so what they found, and what I'm showing here are the Kaplan-Meier curves from their analysis. In the upper left, you have chlamydia, gonorrhea, or syphilis combined as a single metric. In the upper right, gonorrhea, and then in the bottom, chlamydia and syphilis. And so the blue lines are those who were on doxycycline PEP. The red lines in each graph are the participants that did not receive PEP. And the graphs show the cumulative probability of the STI that's being analyzed. And in each graph, I've highlighted the hazard ratio. And so essentially what these graphs show, the one in the upper right, is they found a 47% reduced risk of a new bacterial STI in the doxycycline PEP group. That's, chlamydia, gonorrhea, or syphilis, 47% reduced risk. They found no reduced risk of gonorrhea in the doxycycline PEP group, as shown in the upper right. And then across the bottom with chlamydia and syphilis, 70 and 73% reduced risk of chlamydia and syphilis, respectively. And so the overall findings of this 47% reduced risk of a new bacterial STI largely was driven by the reduced risk for chlamydia or syphilis in people who received doxycycline PEP. So pretty significant risk reduction with the use of a single dose of doxycycline after a high-risk sexual event. A few other important findings here. Majority of gonorrhea and chlamydia was detected from rectal and throat swabs, as previously highlighted by Dr. Altamare. This highlights the importance of testing and screening at all sites of sexual contact. 71% of STIs that were diagnosed were asymptomatic, again, consistent with what Dr. Altamare showed previously and highlights the importance of screening. And then doxycycline adherence, they measured through a number of different measures. During the clinic visits, about 83% reported taking doxycycline within 24 hours of a sex encounter. When they measured plasma concentrations, they only detected doxycycline in about 30% of the PEP group recipients. The caveat here being that the plasma test they did was only able to detect doxycycline use in the previous 48 hours. So not a great test of doxycycline exposure if the test only picks up doxycycline use in the last 2 days. And then what's also important of note with compliance and adherence is that 63% of participants in the doxy PEP group and 25% of those in the non-PEP group had at least one plasma sample with doxycycline detected. So there were a potentially substantial number of people in the comparison group, the non-PEP group, that were found to also be taking doxycycline, which would have potentially watered down their results. And yet they still found a statistically significant risk reduction for prevention of chlamydia and syphilis with using doxycycline PEP. Of note, the study did not assess the impact of the use of doxycycline on antibiotic resistance. Subsequent studies have, however, done that. So what I'm going to show you now is probably one of the main articles and studies that has been conducted and used to develop CDC's draft doxycycline PEP guidance. This is a New England Journal of Medicine article that was just published in about a year ago, April of last year. It was also a randomized open label clinical trial conducted in the US this time, specifically at HIV and sexual health clinics in San Francisco and Seattle. The participants were very similar to the prior studies. So adults, men who have sex with men, or transgender women having sex with men, people taking HIV PrEP. One difference here is that they included HIV positive individuals. And then participants were also at high risk for HIV and high risk for STIs, as defined as a person who was diagnosed with a bacterial STI in the previous 12 months. That, if that sounds familiar, that's because that's what was incorporated into CDC's draft and potentially upcoming PEP guidance. They were randomized 2-to-1. People in the doxycycline PEP group, again, were instructed to take doxycycline 200 milligrams by mouth once within 24 hours, but no later than 72 hours after each high-risk sexual contact. The difference this time is that they had a maximum of once every 24 hours. Remember that in the prior study, the maximum was 3 times per week. In this study, they allowed a maximum of once every 24-hour use of or dosing of doxycycline. They had a number of different outcomes. Again, the primary outcome here being studied was the occurrence of at least one bacterial STI, that's gonorrhea, chlamydia, or syphilis each quarter. So they followed these individuals for 12 months with quarterly scheduled clinic visits where they did testing. And so they did their analysis by quarter. And so if a person was diagnosed with multiple STIs in a single quarter, that person only contributed to the analysis once per quarter. So an important sort of caveat to keep in mind. They also studied tetracycline resistance in gonorrhea isolates as well as Staph aureus isolates. We'll talk more about that. And at each clinic visit, they did chlamydia, gonorrhea, and syphilis testing. Again, similar to the prior study, they took swabs of the throat and rectum and collected urine samples for the chlamydia and gonorrhea testing. They assessed doxycycline adherence. And then what was new in the study is that they took swabs of participant nares and oropharynx to try and culture Staph aureus. So they were looking for Staph aureus colonization, and they did doxycycline resistance testing on those cultures. And of note, the study was stopped early because of the effectiveness of doxycycline post-exposure prophylaxis. When they did the analysis by 2 different cohorts. This is the PrEP cohort. So this is showing the results of doxycycline PEP in participants who were on HIV pre-exposure prophylaxis. That's the Truvada emtricitabine PrEP. And what you can see is that they broke it out by any STI, and then the bottom part of the chart here, gonorrhea, chlamydia, and syphilis. And so what you can see is on the right-hand side where I highlighted the risk ratios is that the doxycycline PEP group showed a approximately 2/3 or 66% reduced risk for the diagnosis of any STI, as highlighted by that relative risk number of 0.34. And you can see then, for any gonorrhea, any chlamydia, or any early syphilis infection, that there were also significant risk reductions with the use of doxycycline PEP. When you get to the chlamydia and syphilis levels, we're talking 87, 88% reduced risk of chlamydia and syphilis individually with the use of doxycycline PEP. So pretty substantial, significant reductions in the risk of these STIs, both combined as well as individually, including with gonorrhea. They also did a separate analysis for participants living with HIV. You can see that they found very similar risk ratios and risk reductions with the use of doxycycline PEP. Tetracycline resistance. They evaluated tetracycline resistance in gonorrhea cultures and Staph aureus cultures. The graph I'm showing here on the left-hand side is looking at gonorrhea cultures. There's a lot of information in these graphs, which might be a little confusing. In parentheses at the bottom, under each baseline versus doxycycline group versus standard of care group, they're showing the total number of cultures that were obtained. And in the bars, they show the percentage of, and the number and percentage of those cultures which came back showing resistance and non-resistance. So they had culture growth in a minority that showed resistance in the dark blue bars and non-resistant gonorrhea in the light blue bars. And you can do sort of simple math to determined that about 27% of gonorrhea isolates that were cultured at baseline were resistant to tetracyclines. And when you look at the proportion that were resistant between the two study groups, 38% resistant versus 12% resistant, there was a difference there in the proportion of gonorrhea results that were resistant to tetracyclines. The clinical significance of this is a little bit unclear because, as Dr. Altamare highlighted, tetracycline is not a recommended antibiotic anymore for treatment of gonorrhea. When they looked at Staph aureus cultures, so very similar graph, but a little more confusing here perhaps. You can see that at baseline, 12% of Staph aureus cultures showed resistance to tetracycline, and between the two study groups at 12 months into the study, in the doxycycline PEP group, 16% of Staph aureus cultures were resistant to tetracycline versus 8% in the standard of care group. Now that also is a higher proportion that were resistant to tetracycline, but what's also of note is that Staph aureus carriage was 40% lower in the doxy PEP group versus standard care group at 12 months. So there's a little bit of a trade-off because there was less carriage detected in people, but slightly higher resistance in the doxycycline PEP group. Again, hard to know the clinical significance of this. 30% of participants had an STI diagnosed at enrollment, so high proportion who came into the study with an STI that was diagnosed and treated. 86% of participants in the doxy PEP group reported taking doxycycline consistently, and they also had a number needed to treat that they calculated of about 5. So that is a pretty low number needed to treat number. So in summary, doxycycline PEP taken within 72 hours of condomless sex decreased gonorrhea, chlamydia, and early syphilis by about 2/3 among men who have sex with men and transgender women. Doxycycline PEP also substantially reduced the occurrence of each bacterial STI individually, including gonorrhea. So when you look at syphilis, it was about a 77 to 87% reduced risk with the use of doxycycline PEP. With chlamydia, 74 to 88% reduced risk with doxycycline PEP. And with gonorrhea, 55 to 57% reduced risk with doxycycline PEP. Now, one of the questions is, well, why do they have a significant reduction in gonorrhea in this study, but not in the prior study conducted in France? And there is some explanation behind this. You know, tetracycline-resistant gonorrhea was more prevalent in France when the prior Lancet article study was conducted, compared to tetracycline-resistant gonorrhea in the US. It's about 56% versus 20% resistant gonorrhea. And this may partly explain the different gonorrhea findings in the two studies. And this becomes important because the final and third study I'm going to show you has that fact, gonorrhea resistance factors in as well. So in the last few minutes, let me highlight this final study looking at doxycycline post-exposure prophylaxis to prevent STIs in women. So this is, again, a randomized open-label clinical trial of women 18 to 30 years of age in Kenya who were not pregnant and were receiving HIV PrEP therapy. They were randomized 1-to-1 to receive doxycycline post-exposure prophylaxis or standard of care. And similar to the last study, the doxy PEP group was instructed to take doxycycline 200 milligrams orally once within 72 hours after each condomless sexual encounter, with a maximum of 200 milligrams or one dose per day. Again, they tracked the occurrence of any bacterial STI each quarter. So similar to the prior study, a person with multiple STIs in a quarter contributed to the analysis only once. They similarly followed these women for 12 months with quarterly clinic visits. They assessed doxycycline adherence at the visits and also by weekly text messages. And interestingly, they also collected hair samples to test for doxycycline exposure, and each hair sample represented about a month of exposure. They importantly also did molecular resistance testing to detect tetracycline resistance in gonorrhea and chlamydia isolates. And what they found was no significant risk reduction in any STIs or chlamydia or gonorrhea individually. So the incidence of bacterial STIs was not significantly lower in the doxy PEP group compared to the standard of care group. There was only one syphilis infection identified, which prevented sort of separating it out in the analysis. And importantly, 100% of gonorrhea isolates showed tetracycline resistance compared to no chlamydia isolates had tetracycline resistance. And so this likely factored into the ability to show any statistical significance with, gonorrhea individually or, in a combined endpoint. There were also issues with doxycycline compliance. So despite about 80% of participants in the PEP group reporting doxycycline use, when they did hair sample testing, doxycycline was detected in at least one visit in only about 56% of participants. And when they excluded participants where doxycycline was on hold, for example, if a woman became pregnant, they had to hold the doxycycline, or if there was concern for pregnancy, they had to hold the doxycycline while they assessed. When they excluded visits where doxycycline was on hold, doxycycline was only detected in about 33% of visits. So this study found that the incidence of bacterial STIs was not significantly lower with doxycycline PEP compared with standard of care in women receiving HIV PrEP in Kenya. And importantly, hair sample testing to assess doxycycline use suggested that doxycycline was not taken during the majority of months. And on top of that, doxycycline-resistant gonorrhea, 100% of isolates showed resistance, likely impacted the ability to show efficacy. So those are the three primary studies, which are published studies, which are the basis for CDC's draft doxycycline PEP guidelines, as shown here. This is what I highlighted previously. This is why the focus of these guidelines is in men who have sex with men and transgender women who are at higher risk for STIs. But this guidance, as it was last reviewed here, does not exclude the possibility of using doxycycline PEP in other populations. It's just that there is insufficient data and more study will be needed. And there are additional recommendations and ancillary services which become important when discussing and counseling patients, including screening for other STIs, as Dr. Altamare highlighted, risk reduction counseling, having that discussion about the risk and the benefits of doxycycline PEP, assessing for HIV PrEP, pre-exposure prophylaxis, and vaccination for other STIs for which there is a vaccine available. So we don't have a lot of time left, but let me just maybe see if Dr. Altamare wants to make any comments. I know the providers are already starting to use doxycycline PEP clinically, given the data, given the draft guidance that has been put out, and we expect more formal guidance to come shortly. But let me just see in the last minute or so if Dr. Altamare has any comments about how this has been implemented clinically in her clinic or in other provider clinics.
Yeah, thanks, Dr. Chan. This was a great overview of all the various studies that have supported this upcoming recommendation. And I have to say that, the patients are also hearing about this through various networks. And so they've been asking more like, hey, should I be on doxy PEP? And so right now we've actually been doing it on an individual kind of risk assessed basis. I have several patients that are on it. And there's, a lot of counseling to go with it. This doesn't obviate the need for barrier protection. It doesn't help all STIs. So there's a lot of kind of the general counseling that you have to give no matter what, including, when prescribing HIV PrEP. I think we talked about it again actually at our team meeting today. And the concern that was raised, I think, by someone else in the chat was, are we worried about antibiotic resistance? And I really do think there's some hesitancy, especially given the data you showed that, we could create more resistant bugs if this was blanketly used for everyone. On the other hand, we could be preventing a lot of unnecessary sexually transmitted infections. So I think there's a hard a fine line to walk right now. And so I don't think people are universally recommending it for sure. And obviously there'll be guidance on strict indications, but the word is out there and patients are definitely asking about it.
Great, that's very helpful. Thanks so much for your input. Thank you to all participants. There's a lot of information here. Thank you very much to Dr. Altamare for her clinical review and comments here at the end. And just as a reminder, these slides and the recorded webinar will be posted online on this website afterwards. So you and others can go back and review not only this webinar, but also the syphilis and congenital syphilis webinar we had back in December. So we're a minute over time. Let me stop and thank you all for your participation. And we will see you back here again next month. Thank you all very much.